Okay, let's unpack this. Today, we are diving deep into a topic that is both incredibly intricate from a medical standpoint and profoundly impactful on human lives. Congenital abnormalities affecting the face, mouth, and jaws.
hmm
When we talk about these conditions, we're really talking about differences that arise during the fundamental processes of development before birth.
And it's a field where complexity is really the norm. These aren't, simple variations. They involve foundational structures that are critical for breathing, feeding, speech, sight, and of course, appearance.
Yeah.
They require a deep understanding of embryology and anatomy to even begin to comprehend.
Exactly. And within this broad category, one condition stands out due to its prevalence.
Yeah.
Cleft lip and palate. The statistic often cited around 1 in 600 live births globally immediately tells you this is a significant health challenge, not a rarity.
Absolutely.
It's something encountered regularly, and its management is far more than just a single operation. It's typically a journey that spans many years involving multiple specialists.
It truly is a lifelong pathway for many patients and their families. And our source material for this deep dive is drawn from a highly respected, comprehensive text in the field of surgery. Bailey and Love's Short Practice of Surgery.
Right.
This gives us access to a really solid, expert-level perspective, drawing directly from a key reference in surgical practice.
Having a source like this is invaluable because it provides, well, a structured look at the material. So our mission today is ambitious. We're going to use this expert resource as our guide to master the core concepts surrounding these congenital craniofacial anomalies. We'll start by understanding the vast range and inherent complexity, explore the fundamental principles that guide how medical teams intervene, and then, as promised, we'll shift our focus to go in-depth on cleft lip and palate, looking at its frequency, how it develops at an embryonic level, and the detailed management strategies employed across a person's life.
Yeah.
Our goal is to equip you, our listener, with a truly robust and nuanced understanding of this often challenging topic.
And mastering this topic requires first appreciating its scale and the different ways these conditions can manifest. Because they are so varied and can involve different tissues and developmental processes, simply describing them can be confusing.
Right. Let's start by getting a lay of the land. The source material immediately points out this inherent complexity and how bewildering it can be due to the sheer variety of these conditions. They aren't neatly packageable.
And that's precisely why classification systems are so crucial in this field. They are attempts to bring order to this complexity, to group conditions with similar features or origins. The source notes that an ideal system would ideally explain the cause, how it develops, and how to treat it. But for conditions that arise from multiple factors and affect structures in so many different ways, that single perfect system is elusive.
So instead of one master key, we have different tools. The source mentions several approaches. There are purely descriptive systems like Tessier's classification for facial clefts. That's named after Paul Tessier, often regarded as a founder of modern craniofacial surgery. His system maps clefts by location, using numbers, describing where the gaps occur across the face and skull.
Yes, a visual anatomical description. Then there are condition-specific systems designed to capture the key features of a particular diagnosis. A great example from the source is the Omen's classification for hemifacial microsomia.
Right.
The system isn't just descriptive. It's particularly useful because it helps in establishing treatment protocols by quantifying the severity of involvement in key areas.
Omens is an acronym, right? Let's spell that out as the source does. O stands for orbital abnormalities, issues with the eye socket.
Correct.
M is for mandibular deformity, the lower jaw.
Yep.
E is for ear deformity. N is for nerve involvement, particularly the facial nerve. And S is for soft tissue abnormalities.
Exactly.
So for hemifacial microsomia, which affects half the face, Omens provides a systematic way to score how severely each of these areas is impacted.
Precisely. It gives clinicians a common language to describe the specific presentation of hemifacial microsomia, which then guides the treatment planning. But the source places significant emphasis on another system proposed by van der Meulen and his colleagues, stating it has significant utility.
Professor Jacques van der Meulen, what makes his embryologically based system so valuable?
Its strength lies in connecting the resulting abnormality back to when and how the developmental disruption occurred during embryogenesis. It helps explain why certain features co-occur by linking them to the developmental processes that went wrong.
Okay, let's delve into the embryological basis that van der Meulen's system considers as described in the source. What are the key processes?
Okay, the system looks at three main processes during the development of the face and skull. First, the formation and fusion of facial processes. These are swellings of tissue that grow and merge together like pieces of a puzzle.
Right.
Failure of these processes to fuse properly is the root cause of clefting disorders. This source gives a classic example. A cleft lip, whether on one side or both, results from the failure of fusion between the front and nasal process, which forms the middle part of the nose and upper lip, and the maxillary processes, which form the cheeks and sides of the upper lip.
So think of those early facial building blocks just not joining up completely. What's the second developmental process?
That's the formation of bone and cartilage. If there's an abnormality in how these structural tissues are laid down or grow, the resulting conditions are termed dysostosis or dyschondrosis.
Okay.
Dysostosis refers to abnormal bone formation, and dyschondrosis refers to abnormal cartilage formation.
Different issues with the skeletal framework itself. And the third?
The formation and growth at the sutures, which are the fibrous joints between the bones of the skull and face. If these sutures fuse together too early, before growth is complete, that's called synostosis. This premature fusion is the underlying mechanism in conditions like craniosynostosis, where the skull shape is distorted because it can't expand normally in certain directions due to the fused suture.
And the source adds a critical superimposed concept to this embryological framework.
Yes, it's essential to also consider the development of the central nervous system. Abnormalities in brain development can occur alongside or influence the craniofacial structures.
I see.
The combination of disruptions in these embryological processes and potential CNS involvement leads to the specific types of abnormalities classified in van der Meulen's system.
So it's a powerful way to categorize based on what went wrong and when. The source provides Table 50.1, listing the types of developmental abnormalities based on this system, with examples. Let's walk through those examples to see the scope.
Absolutely. Type 1. Craniofacial dysplasias involving both dysostosis, abnormal bone, and synostosis, premature suture fusion. Classic examples are Cruzan, Appert, and Pfeiffer syndromes. The source mentions these are named after Louis Cruzan, Eugene Appert, and Rudolf Pfeiffer, who first described them. These are syndromes where the skull fuses too early and there are issues with bone development in the face, often leading to characteristic facial features and eye problems.
Combining skeletal growth issues and fusion problems.
Got it.
Type 2. Craniofacial dysplasias with dyschondrosis abnormal cartilage formation. The primary example given is achondroplasia, which is the most common cause of disproportionate short stature, affecting cartilage growth, particularly in the limbs and skull base.
A condition rooted in cartilage development issues.
Right. Type 3. Cerebrocranial dysplasias, affecting the brain and skull vault. Examples are anencephaly, where the brain and skull don't develop properly, and microcephaly, characterized by a smaller than normal head size, often due to impaired brain growth.
Severe conditions affecting brain and skull formation.
Type 4. Cerebrofacial dysplasias, linking brain and facial development issues. The source lists rhinencephalic and oculoorbital dysplasias affecting structures around the nose, eyes, and orbits.
Conditions involving the nose-brain connection and the eye region.
Type 5. Craniofacial dysplasias with clefting. Now, these are distinct from the common cleft lip and palate. The source lists examples like lateral-nasomaxillary, median-nasomaxillary, intermaxillary, and maxillomandibular clefting.
Oh.
These represent rarer, often more severe facial clefts, following different lines of developmental fusion failure.
These are the less common, more complex facial cleft patterns described by surgeons like Tessier.
Precisely. Then there's a large category, type 6. Craniofacial dysplasias with dysostosis abnormal bone formation without necessarily premature suture fusion. The source lists a significant number of specific types here, named for the bones or regions affected. Sphenoidal, sphenoidal-frontal, frontal-frontal-frontal, frontonasofrontal, frontonasoethmoidal, internasal, premaxillomaxillary and nasomaxillary, maxillozygomatic, zygomatic, zygoromandibular, tempororomandibular, mandibular, and intermandibular.
Wow.
What this extensive list tells us is the incredible specificity and variety of ways that bone development can be disrupted in the face and skull, affecting virtually any bony unit.
That lengthy list really drives home the point about microabnormalities in bone formation. It's not just big syndromes, but precise defects in specific bones.
Exactly. It highlights the level of detail needed to classify them. And finally, type 7. Craniofacial dysplasias with synostosis focus specifically on suture fusion.
Okay.
This is subdivided into craniosynostosis, involving cranial sutures like lambdoid and sagittal synostosis, common in the back and top of the skull. Craniofacial synostosis, involving both cranial and facial sutures like metopic, coronal, and bicoronal synostosis affecting the forehead and sides, and ficus synostosis involving sutures just in the face, with the example of vomeropremaxillary synostosis, also known as binder syndrome, named after Karl-Heinz Binder, which affects the central midface.
So Van der Meulen's system provides this comprehensive framework linking developmental errors to the resulting conditions. It's a powerful tool for understanding why these diverse conditions occur.
It is. And the source is careful to add that even with this detailed system, there's still a large group of craniofacial abnormalities listed in Table 50.1 that don't fit neatly into these 7 embryologically defined types.
Right.
Biology, as always, kind of defies perfect categorization.
That makes sense. It's complex. Transitioning from classification, the source provides general epidemiology data for these conditions. It notes that incidence figures can vary globally and are often hard to quantify precisely.
Yeah, variation in reporting and healthcare infrastructure definitely impacts data accuracy. But Table 50.2 in the source gives us some approximate numbers for the conditions discussed, providing context for their relative rarity or frequency.
Let's run through those numbers.
Sure. Conditions like Apert and Pfeiffer syndromes are quite rare, listed at about 1 in 100,000 live births.
Wow.
Cruzon syndrome is slightly more frequent at 1 in 62,500. Treacher-Collins syndrome, named after Edward Treacher-Collins, is around 1 in 50,000. These are the more well-known, often syndromic conditions with striking facial features.
Still very uncommon in the general population.
Right. The isolated forms of craniosynostosis are more common than the syndromes. Unicoronal synostosis, fusion of one coronal suture, is about 1 in 10,000. Metopic synostosis, forehead suture, is 1 in 7,000. And sagittal synostosis, top of head suture, is the most common single suture synostosis at 1 in 5,000.
So sagittal synostosis is the most frequent cause of an abnormally shaped head due to premature suture fusion.
Yes, among the isolated types. Hemifacial microsomia, which we discussed with omens, is around 1 in 3,500 live births. Neurofibromatosis, which can have significant craniofacial manifestations, is listed at 1 in 2,600.
And then back to the topic of our deeper dive.
Exactly. Cleft lip and palate is listed with an incidence of approximately 1 in 600 live births. This data confirms its status as the most common congenital abnormality discussed in this chapter of the source material. So while the spectrum is vast, cleft lip and palate is the most frequently encountered condition within it.
That really puts its prevalence into perspective compared to the other conditions we've mentioned. Now, on the topic of diagnosis, the source highlights a massive change in recent years.
Yes, this has revolutionized aspects of management. The first front is the significant advancement in ultrasonography technology. Higher resolution scans mean increased rates of prenatal diagnosis for conditions like cleft lip. Knowing about a condition before birth allows for early planning and preparation.
That must make a huge difference for families.
It does. The second front is the rapid expansion of our understanding in genetics. We are now far better at identifying specific genetic mutations and linking them to particular phenotypes, the observable physical characteristics, and medical issues of a condition.
I see.
This helps in understanding the cause and can guide management and genetic counseling for families.
So we can identify more conditions prenatally and sometimes understand the genetic basis.
Yes, those are powerful tools. However, the source makes a crucial point that despite these impressive technological and genetic advances, the diagnosis of the majority of these conditions still fundamentally relies on a clinical assessment, meaning the skilled clinician's physical examination and expertise in recognizing the characteristic patterns of features remain paramount for diagnosis.
That's a really key insight. Technology is a powerful aid, but the human element, the clinical eye, is still central.
Absolutely. Now let's move from diagnosis to management principles. The source is clear from the outset. Generalizing management protocols across this vast range of heterogeneous abnormalities is difficult. Each condition, and indeed each patient presentation, is unique.
And that heterogeneity is why the MDT, the multidisciplinary team, is so essential.
Precisely. The source emphasizes that the vast majority of management for these complex conditions is delivered by highly specialized MDTs located in specialist centers. No single surgeon or doctor can manage all aspects of care for these conditions. It requires a coordinated effort involving multiple specialties working together over many years.
Let's consider prenatal management when a diagnosis is made or suspected before birth. The source mentions experimental surgery.
Yes, there are a few reported cases of highly experimental prenatal surgery for some conditions, but this is still very much in the research phase and not standard clinical practice.
Okay.
In the vast majority of cases where a prenatal diagnosis is made or suspected, The primary options discussed with parents are termination of pregnancy or proceeding with the pregnancy while planning for best supportive care upon birth.
What does best supportive care in this context mean before the baby is born?
It means providing the parents with information, support, and preparation. This includes time to process the diagnosis, learn about the condition, and critically, often connecting them with other families who have children with the same condition or even meeting adults living with it. This support network can be invaluable for preparation and adjustment.
The source also raises the deeply sensitive topic of termination.
It does, noting that termination is a highly contentious issue. The source mentions that parents may, in some circumstances, request termination even for conditions that are considered very treatable, such as an isolated cleft lip. In such a complex and difficult situations, the source notes the involvement of the local ethics board is essential, and in particularly challenging cases, the advice of the courts may even be sought. It underscores the immense personal, ethical, and societal dimensions intertwined with these medical diagnoses.
That really highlights the human impact beyond the clinical details. Moving to the neonatal period immediately after birth, what are the urgent management priorities?
The source identifies the absolute priorities in the neonatal period as addressing airway and breathing issues, ensuring eye protection where needed, and establishing successful feeding. These are critical for the infant's survival and early well-being.
Let's start with airway. How do these conditions compromise breathing in newborns?
Airway obstruction, which can be complete or partial, is a significant risk in many craniofacial conditions. The source explains that a common cause is a retropositioned or setback and hypoplastic or underdeveloped maxilla of the upper jaw.
Right.
This causes the tongue to fall back and obstruct the oropharyngeal airway.
Right.
This problem is often made worse if the mandible, the lower jaw, is also small and set back.
So the skeletal structure isn't holding the airway open properly?
Exactly. In addition, the source mentions that the trachea itself might be abnormal, such as with tracheomalacia, where the trachea walls are floppy and can collapse.
Okay.
And remember, newborns are obligate nasal breathers. They must breathe through their noses. So even nasal obstruction can be a major problem.
What happens in the most severe scenarios?
In the most severe cases described in the source, the abnormal anatomy can make standard intubation impossible, necessitating a tracheostomy, surgically creating an opening in the windpipe to secure the airway. A simple but potentially life-saving emergency measure mentioned is nursing the baby prone on their stomach, which can help the tongue move forward and open the airway.
Simple interventions can be critical in those moments. You mentioned eye protection is also an urgent concern.
Yes, this is particularly vital in syndromic craniosynostoses like Apert, Pfeiffer, and Cruzon syndromes. The source describes how the combination of a setback mid-face and a specific, often broad skull shape resulting from premature suture fusion leads to severe exorbitism, the eyes bulging significantly outwards.
Why is that so dangerous for the eyes?
In the worst cases, this can even lead to ocular dislocation, where the eyelids get trapped behind the eyeball.
Oh my.
More commonly, the severe bulging means the eyelids cannot adequately close over the eye. The source explains that inadequate eyelid closure leads to poor corneal moisturization and protection. If this isn't addressed urgently, it can cause irreversible corneal damage and blindness.
Wow.
Protecting the cornea is thus a critical priority.
That sounds very serious. And the third immediate priority was feeding.
Feeding can be compromised, even without direct anatomical issues, simply because the increased effort required for breathing can make feeding too exhausting for a newborn. But structural anomalies also directly interfere with the ability to suck, swallow, and coordinate feeding. The source highlights the indispensable role of expert input from a specialist feeding nurse.
How do they help facilitate feeding?
They provide practical guidance and support to parents. This includes recommending specialized teats and modified bottles. Soft bottles are mentioned as helpful, allowing parents to gently squeeze the bottle in sync with the baby's suck to deliver milk more efficiently and reduce the baby's effort.
Right.
If necessary, naso or orogastric feeding tube through the nose or mouth directly into the stomach may be required if the baby cannot feed adequately by mouth.
So, stabilizing these fundamental life functions, breathing, sight, feeding, is the absolute focus in the immediate newborn period.
Absolutely. Those are the foundational steps. And from there, the management journey continues, evolving as the child grows.
Let's look at that journey across the lifespan, starting with infancy, from birth to around 12 months.
During infancy, treatment continues to address any major functional issues that persist from the neonatal period. In addition, if the condition involves craniosynostosis, This is the typical window for skull surgery to reshape the skull and allow adequate space for the growing brain.
And as the child enters older childhood,
For children with significant retrognathia, a setback lower jaw, airway compromise might remain a concern. In older children, surgical options to advance the mandible become possible.
what's the purpose of that jaw advancement surgery?
The source states that advancing a severely retrognathic mandible can potentially obviate the need for a tracheostomy, or if a tracheostomy was placed in infancy, it can allow for earlier decannulation, meaning the removal of the tracheostomy tube because the airway is now structurally more secure.
And the technique mentioned for jaw lengthening is distraction osteogenesis.
Yes, also called distraction histogenesis. This is a powerful technique that essentially involves creating new bone. The principle is the same as ling lengthening. A bone is cut, and a device is fitted across the cut ends.
Okay.
After a short waiting period called the latent period, the device is activated to gradually separate the bone ends, typically by about 1 millimeter per day.
And new bone forms in the gap.
Exactly. As the gap is slowly widened, the body lays down new bone tissue in the distraction gap. This is the callus. The source notes a technical detail for the mandible. Unlike long bones, where sometimes only the outer layer is cut, corticotomy, in the mandible, a complete osteotomy, cutting all the way through the bone, is usually performed. Once the desired lengthening is achieved, the device is left in place for a consolidation period to allow the new bone to harden sufficiently.
It's remarkable that you can essentially grow bone through this controlled process. Going back to craniosynostosis, we mentioned surgery in infancy. What's the risk that necessitates intervention?
Craniosynostosis, the premature fusion of skull sutures, whether isolated or part of the syndrome, distorts the skull shape. In syndromic cases, it significantly affects the facial skeleton too. A major concern highlighted in the source is the risk of raised intracranial pressure, ICP.
How common is elevated ICP?
The source states it occurs in 10–20% of cases involving the fusion of single suture, and in a higher proportion of cases involving multiple fused sutures, especially in the syndromic presentations.
Right.
Raised ICP in infants can present subtly with symptoms like unexplained distress, listlessness, and disturbed sleep patterns.
And the long-term consequences.
Elevated ICP can be associated with papilledema, swelling of the optic nerve head in the back of the eye, detectable during an eye examination. Untreated chronic raised ICP can lead to optic nerve damage and irreversible visual failure.
Okay.
Diagnosis is confirmed through intracranial pressure monitoring. This is why surgery to reshape the skull and increase the internal volume is often necessary, not just for cosmetic reasons, but to protect the brain and vision.
So, skull surgery is often about pressure release and brain growth as much as it is about shape. You also brought up eye protection earlier. Are there other ocular issues?
Yes, some congenital lesions can directly obstruct a child's vision. It's vital to address these promptly to minimize the risk of amblyopia developing.
Amblyopia, sometimes called lazy eye, where the brain suppresses the image from the affected eye because it's receiving a poor signal, leading to reduced vision that can become permanent if not treated early.
Exactly. The source gives this specific example of a large true hemangioma, a type of vascular tumor located on the eyelids that is threatening to block vision in one eye.
Right.
Such lesions require timely intervention, often surgical or medical, to clear the visual axis and allow normal visual development.
As we move into early childhood, say from 1 to 12 years old, does the focus of management shift?
Yes, the priorities evolve. While addressing persistent functional problems like airway issues, speech development, and feeding difficulties remains important, there's an increasing emphasis placed on surgical interventions to improve the child's appearance.
Why does appearance become more pressing at this age?
The source explicitly states that there is no doubt that visible differences can have a significant impact on a child's social and emotional development as they interact more with peers and the wider world. Managing the psychosocial aspects is critical. The source stresses the vital role of psychological and emotional support for the child, the family, and even the school community to help navigate the challenges that visible differences can present.
When is surgery for appearance typically done?
The source notes that while surgery can be offered for pressing psychological reasons, for many patients, achieving the optimal long-term aesthetic and functional outcome means that significant surgery, especially procedures affecting bone structure, should ideally be delayed as long as possible, often until growth is nearly complete. This highlights a difficult balance for families and clinicians.
Are airway issues still a concern in older children?
Yes, they can persist or develop insidiously. The source points out that identification can be harder in older children compared to neonates. Sleep apnea is a common presentation, which can have a slow, subtle onset.
Right.
Parents might become accustomed to chronic snoring and daytime tiredness and not fully appreciate the severity of the underlying breathing problem during sleep.
How is suspected sleep apnea investigated in this age group?
The initial investigation often involves a home overnight oxygen saturation monitor to screen for drops in oxygen levels during sleep. If this is abnormal, it warrants a more comprehensive sleep study to get a full picture of their respiratory patterns, including airflow, breathing effort, and brain activity, often conducted in a sleep lab.
And the management options for obstructive sleep apnea?
Management depends on the cause and severity. Options mentioned in the source include tonsillectomy and adenoidectomy, if enlarged adenoids or tonsils are contributing, mid-face advancement surgery if the upper jaw is set back and obstructing the airway, mandibular distraction surgery for lower jaw deficiency, or the use of ventilator support devices like CPAP or BiPAP during sleep.
Finally, looking at late childhood through to maturity, what's the focus during these years?
By this stage, most primary functional issues like critical airway problems or significant feeding difficulties are usually stabilized. The focus in late adolescence and early adulthood shifts primarily to optimizing the overall aesthetic appearance and ensuring stable functional outcomes, particularly bite alignment. The source notes that the transition from primary to secondary school can often be a period of significant distress for patients and their families due to increased social awareness and potential peer issues related to appearance.
When are the major cosmetic or skeletal corrections typically planned?
While surgery can be offered earlier for compelling psychological reasons, the source states that major surgical procedures to correct underlying skeletal and significant soft tissue discrepancies are usually best postponed until growth is complete.
Okay.
This ensures the correction is performed on a stable framework and is less likely to be negatively impacted by further growth.
And the overall approach to this final stage of correction?
The source emphasizes that a comprehensive, integrated corrective plan is developed within the MDT. This plan typically addresses the underlying skeletal and dental abnormalities first, establishing the cray-jaw relationships and aligning the teeth, and then proceeds to address any remaining soft tissue aesthetic concerns.
Skeletal first, then soft tissue.
Exactly. The source reiterates that major craniofacial abnormalities should be managed by a formal MDT, emphasizing the continued need for multidisciplinary expertise throughout the lifespan.
This layered, staged approach, starting with life-sustaining functions and evolving towards optimizing long-term function and appearance, really is a defining feature of managing these complex conditions. Now, let's narrow our focus, as promised, and dive deep specifically into cleft lip and palate, the most common condition in this category.
Right, as we established, cleft lip and/or palate is the most common congenital abnormality affecting the orofacial region, with an incidence of around 1 in 600 live births globally. It's crucial to understand that while it often occurs in isolation, meaning it's the only congenital issue, it can also be associated with other medical conditions.
Such as?
The source gives the example of congenital heart disease, which can sometimes be seen in babies with clefts. Even more significantly, cleft lip and/or palate is recognized as a feature in over 300 distinct syndromes.
Wow, that's a vast number of syndromes. Does that mean if a baby is born with a cleft, they are automatically screened for other problems?
Yes. The source states that all children born with a cleft are screened for other congenital abnormalities to rule out or identify any associated conditions.
Okay.
If the presentation suggests the cleft is part of a wider syndrome, further appropriate investigations and genetic counseling are organized for the family.
Let's revisit the incidence numbers for clefts specifically. We know it's 1 in 600 overall, but the source mentions geographical and ethnic variations.
Yes, there are reported variations. Incidence is said to be higher in Southeast Asian populations and Native American populations compared to, for example, Caucasian populations, around 1 in 1,000, or African populations, around 1 in 2,500. The source does add a caveat that variations in reporting standards and healthcare infrastructure globally mean the accuracy of these specific ethnic or geographical variations should be considered with some caution.
What about the breakdown of cleft types? The source provides figure 50.1 illustrating these.
The distribution typically breaks down as follows. Isolated cleft lip, meaning the lip is affected but not the palate, accounts for about 15% of cases. Cleft lip and palate combined is the largest group, representing about 45% of cases. And isolated cleft palate, where the palate is involved but the lip is not, accounts for about 40% of cases.
So, Combining cleft lip and palate with isolated cleft palate. The palate is involved in the vast majority of cases, around 85%. This means palate-related issues like feeding and speech are very frequently part of the picture.
That's a key takeaway for those figures. Now, classifying the specific type of cleft in a patient is important because they present in a heterogeneous manner, meaning there's lots of variation in the extent and severity.
How do clinicians approach classification given that variability?
The source notes they can be broadly simplified into two clinical phenotypes for ease of understanding. One, isolated cleft palate, and two, cleft lip with or without involvement of the alveolus, the tooth-bearing ridge, or the palate. Within these two broad types, there's a variety of combinations describing the extent and the laterality, left, right, or bilateral. This detailed classification is important for diagnosis and, increasingly, for prognosis, helping predict potential outcomes and associated issues.
Is there a universally agreed-upon system for describing these combinations?
The source notes that while many have argued for a single, simple system, there's still inconsistency even when the same system is used by different clinicians. Figure 50.2 in the source shows examples of classification systems. One is the Al-Ishel code, an acronym where L is for lip, A for alveolus, H for hard palate, and S for soft palate, with uppercase indicating complete cleft and lowercase indicating incomplete cleft, and R or L denoting the side, or B for bilateral.
Okay.
Another mentioned is the Vaux classification system, named after Victor Vaux, which uses Roman numerals, classes IIV, to describe increasing severity, from class I being soft palate only to class 4 being complete bilateral cleft, involving lip, alveolus, and palate.
So different systems exist to try and capture the precise anatomy of the cleft for communication and research.
Exactly. The source also mentions the use of national audit data, citing the UK as an example, for unilateral cleft lip and palate, the UCLP, which allows for inter-center comparison of outcomes and helps drive quality improvement and evidence-based practice.
Any other interesting patterns in the incidence data?
Yes, there are noted sex differences. Cleft lip and palate is more common in males, while isolated cleft palate is more common in females.
Interesting.
Also, in unilateral cleft lip and palate, the condition affects the left side in 60% of cases compared to the right.
More left-sided UCLP and isolated palates more common in girls. Okay, what about the causes, the etiology of non-syndromic clefts?
Non-syndromic clefts, meaning those not part of a recognized syndrome, can either occur sporadically as a new diagnosis in a family, or they can have a clear family history. Having a first-degree relative with a cleft does increase the risk, strongly supporting an underlying genetic component playing a role. It's not a single gene causing it, but often a combination of genetic factors.
So genetics are involved even if it's not part of a known syndrome. And you mentioned over 150 syndromes are associated with clefts. Which are the ones most frequently seen in practice, according to the source?
The source lists several key syndromes frequently associated with clefts. Stickler syndrome, which involves issues with collagen impacting eyes, hearing, and joints. DeGeorge syndrome, a genetic disorder affecting facial development, heart, immune system, and more. Down syndrome, trisomy 21, and the craniosynostosis syndromes we discussed earlier, Apert and Treacher-Collins syndromes.
Stickler, DeGeorge, Down, Apert, Treacher-Collins. Those are important names in the clinical context of clefts.
What about environmental factors that can increase risk?
The source notes that various environmental factors have been implicated. Maternal epilepsy is mentioned, and specifically the medications used to treat epilepsy during pregnancy.
Certain drugs taken during pregnancy are listed as potential risk factors. Steroids, diazepam, a sedative, sodium valproate, and phenytoin, both anti-epileptic drugs.
And folic acid, which is widely recommended prenatally to prevent neural tube defects.
The source's statement on folic acid's role in preventing cleft lip and bore palate is notable. It states that the role of antenatal folic acid supplements remains equivocal. This means the evidence linking folic acid intake specifically to the prevention of clefts is not as clear or definitive as it is for conditions like spina bifida.
That's an interesting nuance. It's not that it has no effect, but the evidence isn't as conclusive compared to other birth defects. The source highlights one specific condition associated with isolated cleft palate as being worth considering in specific terms. Pierre-Robin sequence.
Pierre-Robin sequence, or PRS, is a condition strongly associated with isolated cleft palate and poses significant challenges, particularly early on. It's a sequence because one primary developmental issue triggers a cascade of subsequent problems. The sequence consists of three core features: an isolated cleft palate, meaning the lip is intact; micrognathia or retrognathia, a very small and set back lower jaw, and glossoptosis,
Mm.
the tongue being displaced posteriorly or towards the back.
Isolated cleft palate, tiny jaw, tongue pushed back. It's immediately clear why airway and feeding would be compromised.
Exactly. The source emphasizes that while airway obstruction is not common in non-syndromic cleft lip and palate, it is a significant, potentially life-threatening issue in babies with Pierre-Robin sequence.
Mm.
This is because the small setback jaw cannot hold the tongue forward, and the tongue falls back into the pharynx, especially when the baby's lying on their back, causing hypoxic episodes, periods, where oxygen levels in the blood drop dangerously low, particularly during feeding or sleep.
How is Pierre-Robin sequence typically managed?
Mild or intermittent airway obstruction can sometimes be managed conservatively, for example, by nursing the baby in a prone position or on their side to help the tongue fall forward. However, children with more severe compromise often require adjunctive support for their airway. This can include supplemental oxygen, using a nasopharyngeal airway, a soft tube inserted through the nose into the pharynx to create an air channel, and in the most severe cases, as we discussed earlier, even a tracheostomy may be necessary to secure the airway.
The source also mentions surgical options, though, with some caution.
Yes, it mentions surgical adhesion of the tongue to the lower lip, called labioglossopexy, as an alternative surgical option, though describes it as controversial and less commonly practiced.
Right.
Mandibular distraction surgery, which we discussed for general retrognathia, also has advocates for use in severe PRS to lengthen the lower jaw and move the tongue base forward, thereby opening the airway. However, the source notes that despite numerous attempts, a clear consensus view supporting this procedure specifically for airway compromising cleft patients, like those with PRS, has not been achieved. This suggests that while the technique exists, its optimal role and timing in PRS management are still debated among experts.
That underscores the complexity of managing these conditions, even within specific syndromes. Let's now really hone in on the embryology and pathogenesis of clefts themselves, going deeper into how they form based on the source. It talks about derivation from facial prominences again.
Yes, reiterating those early building blocks is crucial for understanding the anatomy of a cleft. The source describes the upper lip and nose complex as deriving from the median nasal process and the paired maxillary processes.
And the palate.
The palate's development is complex and divided into the primary and secondary palate, separated by the incisive foramen. The primary palate, formed from the median nasal process, is the small anterior part, in front of the incisive foramen.
Okay.
It gives rise to the alveolus carrying the incisor teeth and the philtral portion of the upper lip, that little vertical groove and ridges in the center of your upper lip. The rest of the upper lip is formed from the maxillary processes.
So primary palate is the very front part, alveolus and philtrum, from the median nasal process.
Correct. The secondary palate, which forms the bulk of the palate behind the incisive foramen, is derived from the maxillary processes. These processes grow into shelves that initially hang vertically, but then elevate and fuse in the midline to form the hard palate anteriorly and the soft palate posteriorly.
And cleft palate is a failure of this fusion.
Precisely. Cleft palate results from the failure of these two palatine shelves to either elevate or fuse properly in the midline. This failure can affect any part of the palate, from just the uvula, the little hanging part of the back, to the entire hard and soft palate.
Understanding that developmental process is key to understanding the resulting anatomy. Let's look at the clinical anatomy of clefts, building on how they form. The source mentions muscle chains and disruption, showing figure 50.3.
Yes, the source highlights that the visible abnormalities in a cleft lip and palate are a direct consequence of the disruption of the muscles of the upper lip and nasolabial region. The muscle fibers, which normally form a continuous ring around the mouth, are pulled away from the midline cleft edge and insert abnormally. This muscle disruption doesn't just create a gap in the lip, it also pulls on and deforms the surrounding structures, notably the nasal septum and the external nose.
So the muscle issue is fundamental to both the gap and the distortion of the nose.
Exactly. In a unilateral cleft lip, the muscle disruption is on one side. This causes the lip and nose to be asymmetrical. The deformity involves the external nasal cartilages, the nasal septum, and the anterior maxilla, or premaxilla.
Right.
The disruption also significantly influences the mucocutaneous tissues, the specialized pink tissue of the lip vermilion, and the border between it and the skin. Figure 50.4 in the source is really illustrative here, showing how the muscle fibers, like the orbicularis oris that circles the mouth, are pulled superiorly and laterally towards the base of the nose and the cheek, away from where they should meet in the midline.
Ah, I see.
Understanding this specific muscle abnormality is vital for surgical planning, as the goal is to reconstruct this disrupted muscle ring.
It's about repositioning and reconnecting the muscles, not just closing the skin.
Precisely. In a bilateral cleft lip, the muscle disruption occurs on both sides. This often results in a greater, though sometimes more symmetrical, deformity. The lack of muscular continuity causes the nose to flare outwards. There's also often a protrusive premaxilla. The bone holding the front teeth juts forward, and the central strip of skin in front of it, called the prolabium, is often significantly underdeveloped and notably devoid of muscle. This prolabium needs careful handling during surgery.
Okay.
Like unilateral clefts, the mucocutaneous tissues are affected and must be respected during planning.
That central muscle-free prolabium sounds like a key anatomical challenge in bilateral clefts. Moving to cleft palate anatomy, distinct from the lip, we define primary and secondary palate and the incisive form and boundary. How does a cleft affect the hard and soft palate structures?
A cleft palate results from the failure of fusion of the palatine shelves, and it can be confined to the soft palate only or involve both the hard and soft palate. The source distinguishes between incomplete and complete hard palate clefts.
Okay.
In an incomplete hard palate cleft, the palatine shelves have fused partially, and the remaining cleft is attached to the nasal septum and vomer bone. In a complete hard palate cleft, the palatine shelves have completely failed to fuse with each other and with the nasal septum vomer, leaving the septum and vomer free or attached to neither palatine shelf.
So, attachment to the nasal septum is the key difference between complete and incomplete hard palate clefts?
Yes, that attachment provides some structural continuity in an incomplete cleft. Now, the soft palate anatomy is particularly important because it's critical for speech and swallowing. The source notes that proper velopharynx closure, the lifting of the soft palate to close off the space between the mouth and nose during speech sounds, is essential for normal speech.
Right.
The key muscle for this movement is the levator veli palatini.
How is this muscle different in a cleft palate?
Normally, the levator veli palatini muscles run transversely across the soft palate and interdigitate in the midline, forming a muscular sling with minimal attachment to the hard palate. In a cleft soft palate, however, the muscle fibers are oriented in an abnormal anteroposterior direction, running from front to back, and they insert into the posterior edge of the hard palate.
Ah, okay.
The source is very clear. The principal surgical goal in cleft palate repair is to dissect these abnormally oriented muscles free from their hard palate insertion and suture them together in the midline. This maneuver, called intravelar veloplasty, aims to recreate a functional muscular sling with a more normal transverse orientation.
This detail about the muscle orientation and the surgical goal of recreating the sling is fundamental to understanding palate repair and its impact on speech. It's not just sewing the layers together, it's rebuilding the engine of palatal function.
Exactly. The source emphasizes that restoring this transverse muscular sling is critical for achieving good velopharyngeal function and normal speech. The hard palate anatomy is also described in detail, divided into 3 anatomical and physiological zones, illustrated in Figure 50.5.
Okay.
Zone 1 is the central palatal fibromucosa, which is very thin and forms the roof of the mouth immediately below the floor of the nose. Zone 2 is the maxillary fibromucosa, which is much thicker and laterally contains the important greater palatine neurovascular bundle of blood vessels and nerves that supply the palate.
Right.
Zone 3 is the gingival fibromucosa, located most laterally, adjacent to the teeth.
Why is understanding these zones important for surgery?
The source explains that successfully closing a cleft palate, particularly a complete one, requires understanding how the cleft affects these zones. In complete cleft palate, the central zone 1 tissue is reduced or absent at the midline cleft edge. However, the lateral zones 2 and 3, containing the bulkier tissue and the vital neurovascular bundle, are present. Surgeons use flaps of tissue, often incorporating these lateral zones and the neurovascular bundle, to close the midline defect. Respecting the location of the neurovascular bundle is critical to maintain blood supply to the flaps.
Got it.
Understanding these tissue differences and distributions is necessary to plan and execute an anatomical and functional repair.
That level of anatomical detail really shows the precision required in cleft surgery. It's not a simple closure, it's a complex reconstruction. With this detailed understanding of the anatomy and how it's disrupted, let's return to the cleft team and the principles of primary management.
Modern cleft care, as the source emphasizes, citing the UK model as an example, is delivered through well-coordinated multidisciplinary teams working within specialist centers.
Right.
This team approach is essential for managing the complex, long-term needs of patients with clefts. ensuring they access the right specialist at the optimal time throughout their development. Care begins early, often right from diagnosis.
And diagnosis can happen antenatally now.
Yes, for clefts involving the lip, antenatal diagnosis is relatively common and is often picked up during the routine anatomy span around 20 weeks of pregnancy.
Okay.
Isolated cleft palate, however, is often missed on routine antenatal ultrasound, though some suggest Doppler studies might help. When an antenatal diagnosis is confirmed, the source notes that referral to the specialist cleft team should occur immediately.
And that's where the clinical nurse specialist comes in early on.
Absolutely. The source states that the CNS, or clinical nurse specialist, plays a central role in the safe and effective delivery of cleft care. They are often the first clinical contact for the family after diagnosis, whether antenatal or postnatal. They assess the child's feeding, airway, and general well-being, provide essential support and education to the family, and are crucial in preparing the child and family for planned surgeries.
Let's walk through the key roles within the Cleft MDT as described in the source, highlighting their specific contributions.
Okay, first, the cleft coordinator or administrator. This role, while administrative, is vital for organizing the patient pathways, appointments, and communication, ensuring smooth navigation of complex, long-term care for families and clinicians. Responsive administrative support is key.
Then, the pediatrician.
The pediatrician is essential because while many children with clefts are healthy otherwise, some do have associated medical conditions, like the cardiac issues mentioned earlier. The pediatrician manages these coexisting problems and helps coordinate overall medical care.
The speech and language therapist, or SLT.
Their input is absolutely vital, particularly with palatal involvement. They assess speech development, provide therapy, measure outcomes of palatal repair on speech, and are key in diagnosing issues like palatal dysfunction that can impact speech.
ENT and audiology.
Their role is crucial from early on. Children with cleft palate have a higher incidence of middle ear effusion, glue ear, due to eustachian tube dysfunction, which can impair hearing. Regular audiological screening and effective intervention for hearing loss are vital to ensure normal speech and language development.
Pediatric dentist.
Traditionally, oral health in children with clefts could be challenging, but with increased emphasis on prevention, outcomes have improved. The pediatric dentist provides early dental health care, focusing on prevention through diet advice, fluoride use and sealants, and managing dental anomalies common in cleft patients. Good oral health is foundational for later orthodontic treatment.
The orthodontist. Their role seems to span many years.
It definitely does. While some units use early orthodontic appliances, like nasal alveolar molding in infancy, though the source notes conflicting evidence on long-term benefit, the orthodontist becomes critically important around age 78 during the mixed dentition phase.
Right.
They assess and prepare the dental arches for alveolar bone grafting, perform definitive orthodontic alignment in adolescence, and prepare patients for orthognathic surgery if needed later.
Clinical psychologist.
These clinicians provide essential psychosocial support to patients and their families throughout the entire treatment pathway. They also contribute to assessing outcomes related to quality of life and well-being.
And finally, the cleft surgeon.
The cleft surgeon assesses the patient, plans, and performs the surgical interventions to correct the underlying anatomical abnormalities, aiming to improve both appearance and function. The source notes that the goal is optimal outcomes with limited surgical procedures, typically only 1 to 3 planned operations over childhood, depending on the cleft type. Their outcomes are typically audited annually.
That gives a clear picture of the dedicated expertise within the team. Let's revisit the immediate neonatal care, specifically for babies with clefts. Building on the general points, feeding is a big one.
Yes, feeding and potential airway issues are the immediate concerns. For babies with a cleft involving the palate, the source is reassuring. They can feed well and thrive, provided they receive appropriate input from the CNS and team. Feeding aids are crucial to make feeding more efficient and less tiring.
What kind of aids are typically used?
Express breast milk is often recommended as ideal. Various modified bottles and teats are available. Soft bottles are helpful, as parents can synchronize a gentle squeeze with the baby's suck to assist milk delivery.
Okay.
The source also mentions that feeding plates, made from a dental impression of the baby's palate, were historically used in the UK and are still used in some centers to help create a separation between the mouth and nasal cavity during feeding, although their routine use has decreased in some places.
And nasoalveolar molding? NM, you mentioned earlier?
NM is a technique used in some units involving an active plate molded to the baby's gum ridges and nose. It's used pre-surgically with the goals of improving feeding and also actively reducing the width of the alveolar cleft and improving the shape of the nose before lip repair.
Right.
However, as noted, the source mentions conflicting evidence in the literature regarding its long-term benefits, so its use varies.
Interesting that even for a technique like that, there's ongoing debate.
Yes, it highlights the dynamic nature of the field. The source's summary box 50.4 reinforces key points about immediate care, potential feeding airway issues, the necessity of the team, and importantly that most of the care delivered in the initial phase is non-surgical. It's primarily about support, monitoring, and optimizing function through non-operative means while planning for future surgery.
That non-surgical initial focus is perhaps counterintuitive, but makes sense for stabilizing the baby. Now, let's delve into the principles of cleft surgery itself and the typical staged approach described in the source.
The ultimate aim of cleft lip and palate management, including surgery, is to facilitate normal physical, psychological, and social development and overall well-being. The surgical interventions aim to produce normal or near-normal anatomy in the lip, nose, and palate, and to optimize oral and dental health, all of which contribute to those outcomes.
What are the key outcomes the teams track to measure success?
The source lists speech function, facial growth patterns, the patient's general well-being, and dental health as the key outcomes that are monitored over the long term.
And regarding the tissue itself, is it truly missing tissue that needs to be replaced?
This is a critical point the source clarifies. With the exception of rare conditions, there is generally no true hypoplasia, meaning a significant lack of tissue on either side of the cleft.
Okay.
Instead, the tissue is present but is displaced, deformed, and there's underdevelopment of the associated muscles and facial skeleton.
So it's less about filling a void and more about rearranging and reconstructing existing structures.
Exactly. And because of this, the source places a strong emphasis on muscular reconstruction of the lip, nose, face, and especially the soft palate muscles. Reestablishing the continuity and normal orientation of these muscles is paramount for both functional outcomes like speech and breathing and aesthetic outcomes.
That emphasis on muscle reconstruction seems like a core principle. Does that mean understanding the normal anatomy is absolutely essential for the surgeon?
Absolutely. The source states that an in-depth understanding of normal anatomy is invaluable because it allows the surgeon to achieve a normal or near-normal anatomical reconstruction.
Right.
This, in turn, promotes normal function, which helps encourage normal growth and development of the affected craniofacial structures over time.
What about the surgical techniques and the timing? The source mentions a typical staged protocol used in the UK, influenced by methods popularized in Norway.
Yes, there's historical debate and ongoing variation globally in the precise timing and techniques used. But the protocol described in the source is a staged approach over childhood.
What happens in stage 1?
Stage 1 involves the repair of the cleft lip, nose, and the anterior part of the palate, if involved. This is typically performed between 3 and 6 months of age. Figures 50.6 and 50.7 in the source show examples of the aesthetic result after lip repair.
Okay.
The anterior palate closure, if needed, for example closing the gap in the gum line, is often achieved using a single-layer mucosal flap rotated from the vomer bone in the midline.
And the lip repair itself?
Numerous surgical techniques exist for lip repair. The source notes that while the specific skin incisions vary between techniques, most surgeons agree that the repair of the underlying disrupted muscle layer is more important than the skin closure alone. This emphasis on muscle reconstruction explains why different techniques for skin closure might be used while adhering to the core principle of muscle repair.
Stage 1 focuses on the lip and the very front of the palate. What about stage 2, the definitive palate repair?
Stage 2 is the definitive repair of the hard and soft palate, typically carried out between 6 and 12 months of age. The principle guiding this timing, particularly in the UK protocol described, is to perform the repair during the early stages of speech development. However, this source does acknowledge that there is conflicting evidence in the published literature regarding the optimal timing of palate repair globally in relation to speech outcomes. This remains an area of ongoing research and clinical debate.
So while the UK protocol favors earlier timing to support speech, other centers might differ. What's the most common surgical technique for the palate repair itself?
The most common approach described is the intravelar veloplasty, or IVVP. This technique involves making incisions along the cleft edges to access the soft palate muscles.
Okay.
The levator velopalatini muscles, which are abnormally oriented front to back in a cleft palate, as we discussed, see figure 50.8 showing them dissected, are carefully dissected free from their abnormal insertions into the hard palate. The key step is then suturing these dissected muscles together in the midline to recreate a functional muscular sling that can lift the soft palate effectively for velopharyngeal closure.
Recreating that muscle sling is the functional heart of the palate repair.
It is. This shift from the abnormal anteroposterior orientation to a more normal transverse orientation is crucial for improving velopharyngeal function. The source summarizes primary surgery in box 50.5. Treatment is staged, often anterior to posterior. Lip repair involves multiple skin incisions, but muscle reconstruction is key, and managing the levator sling is the critical technical step in cleft palate repair.
After these primary surgeries are completed in infancy, what does the long-term care and follow-up involve?
Post-primary surgery, regular review by the multidisciplinary cleft team is essential and continues for many years. The source details several key areas that require ongoing monitoring and potential intervention during the early years, typically from age 1 to 7. These include hearing, speech, dental development, and addressing any issues with wound healing or aesthetics.
Starting with hearing, how is that affected?
As mentioned earlier, eustachian tube dysfunction is very common in children with cleft palate. This dysfunction leads to a high incidence of otitis media with effusion, OME, often called glue ear fluid buildup in the middle ear space.
Right.
This is significantly more common in children with palatal involvement than those with just a cleft lip. Because normal hearing is absolutely vital for normal speech and language development, all children with cleft palate have routine audiological screening and management of any detected hearing loss.
And speech development itself.
Specialist speech and language therapists, SLTs, are involved early in the UK pathway. They monitor development and provide therapy. Some teams run group sessions for families to support early communication skills. There is constant monitoring of speech, and early intervention is crucial if any speech pathology is suspected or diagnosed.
What are the specific speech problems most commonly seen after palate repair?
The source breaks them down into two broad categories. The first is velopharyngeal incompetence, VPI. This occurs when the soft palate and pharyngeal walls cannot adequately close off the space between the oral and nasal cavities during speech, particularly for sounds that require high intraoral pressure, like PTK. Air escapes into the nose, resulting in hypernasality, a resonance disorder where the voice sounds too nasal. This can make speech difficult to understand, either due to the hypernasality itself or compensatory ways the child adapts, like using glottal stops.
So VPI is a functional issue with the palate not closing properly. What's the second category?
Articulation errors. These are difficulties producing specific speech sounds correctly. In children with cleft palate, articulation errors can occur as a compensatory strategy the child develops to try and overcome VPI. Less commonly, they can be caused by structural problems with the jaws, teeth, or bite. Occlusion.
How are VPI and articulation errors diagnosed and investigated by the team?
Diagnosis relies on specialist SLT assessment, often involving listening carefully to the child's speech. If VPI is suspected to have a structural cause, the team may perform instrumental investigations to visualize the velopharyngeal mechanism in action.
Right.
The source mentions lateral video fluoroscopy and nasendoscopy as methods used to visualize the movement of the palate and pharyngeal walls during speech, helping the SLT and surgeon understand the specific functional problem.
And if the palate repair function is inadequate or there's VPI?
Secondary speech surgery may be offered to improve function. This could involve a re-repair of the palate if the initial surgical outcome is deemed suboptimal, or, more commonly, procedures broadly termed pharyngoplasty.
Okay.
The source explains that pharyngoplasty procedures involve surgically altering the structures of the pharynx to create a narrower opening or a flap that partially closes the velopharyngeal port, thereby altering the airflow dynamics during speech to reduce nasal escape and hypernasality.
So there are surgical options specifically to improve speech function after primary repair. What about dental development in these years?
Dental anomalies are very common in children with clefts, particularly those involving the alveolus and palate. The source lists delayed tooth development and eruption and morphological abnormalities, abnormally shaped teeth. Issues with the number of teeth are also frequent, including hypodontia, missing teeth, or hyperdontia, extra teeth. These problems most commonly occur in the region of the cleft alveolus, often affecting the maxillary lateral incisor, the tooth next to the front teeth. These anomalies can affect both the primary, baby, and secondary, adult dentition.
Regular dental care must be essential.
Absolutely. The source stresses that all children with cleft lip and palate should have regular dental examinations from an early age. Preventive measures like dietary advice, fluoride supplements, and fissure sealants are crucial to maintain good oral health.
Right.
A healthy, well-maintained dentition is essential for successful orthodontic treatment and potential later restorative work.
And finally, wound healing and aesthetics in these early years.
Infections after primary surgery are rare, but can sometimes lead to complications requiring revision surgery. Minor lip revisions might be timed before the child starts school or opportunistically later. Issues related to palatal function like VPI, if persistent after therapy and assessed structurally, would lead to discussion about re-repair or pharyngoplasty, as we just discussed.
Moving into late childhood, typically ages 7 to 12, a significant surgical intervention occurs for patients with alveolar clefts, alveolar bone grafting, or ABG.
ABG is a key procedure for closing the gap in the tooth-bearing ridge of the upper jaw. The source distinguishes between primary bone grafting done with the initial lip repair, less common now, and secondary bone grafting, which is a separate procedure performed later in development. Secondary ABG is much more commonly practiced.
And the timing of this secondary ABG is described as crucial.
It is absolutely critical and is timed specifically to the development of the underlying adult dentition in the region of the cleft. Dental development is assessed using dental x-rays. The optimal window for ABG is linked to the root development of the canine tooth, which is the tooth usually located immediately behind the cleft in the dental arch. When the canine root is about 1/2 to 2/3 formed, that's considered the ideal timing. This often falls between the ages of 8 and 11, but the source strongly emphasizes that individual assessment of dental development via radiograph is more important than relying strictly on chronological age.
Why is the canine tooth used for timing?
The canine is consistently present and erupts relatively late in this area. Grafting at the right time allows the canine, or sometimes the lateral incisor if present, to erupt into the newly placed bone, consolidating it and establishing bony continuity across the arch.
Is orthodontic treatment always needed before ABG?
The source states that less than 50% of patients with unilateral cleft lip and palate require orthodontic treatment before ABG. If needed, this pre-graft orthodontics aims to expand the alveolar cleft slightly to improve surgical access for placing the bone graft, and occasionally to align adjacent teeth that might interfere with the graft or future eruption. Pre-graft orthodontics is described as vital in bilateral clefts because it helps to stabilize the often mobile, protruding premaxillary segment, which is essential for successful bone healing after the graft is placed in the gaps on either side of it.
Right, vital for bilateral.
Yes. Adjunctive procedures, like a lip revision, can sometimes be performed simultaneously with the ABG.
What's the success rate for ABG?
The source indicates a high success rate for ABG. Various scoring systems are used to objectively assess the outcome. The source also emphasizes that vital teamwork and communication between the cleft surgeon performing the graft and the orthodontist is crucial for optimal success.
What if ABG isn't done, perhaps due to missing teeth?
If there is significant hypodontia missing teeth in the cleft area, a decision might be made not to proceed with ABG at this stage. In such cases, the missing teeth will need to be replaced with restorative options later in life, such as a denture, an adhesive bridge, or an implant-retained prosthesis. However, the source notes that even for placing dental implants, bone grafting would still be required to provide sufficient bone volume to anchor the implant, but this would be done later when the patient is skeletally mature.
So bone grafting might still be needed later for implants, but it's a separate procedure from the ABG timed for tooth eruption. What are the primary objectives of performing ABG, as listed in the source? There are 4 key goals.
The 4 primary objectives listed are: 1. To provide adequate bony support for the adult teeth that erupt into the area, enabling subsequent orthodontic alignment of those teeth. 2. To enable the eruption of those adult teeth into the line of the dental arch. 3. In bilateral clefts, to stabilize the often mobile premaxilla. And 4. To definitively close the residual alveolar cleft, providing continuity of the gum line and bone across the defect.
Those are clear functional goals. Any secondary benefits?
Yes, the source mentions secondary objectives or associated benefits, which include aesthetic improvements to the nasolabial region, the area of the lip and nose resulting from closing the bony defect and providing better support for the overlying soft tissues.
Orthodontic treatment plays a significant role in late childhood and adolescence, too.
It's essential for many patients with cleft lip and alveolar involvement. Orthodontic treatment is commonly carried out in 2 phases. The first phase is often in the mixed dentition, ages 8-10, primarily, as discussed, to repair the alveolar cleft for ABG.
Right.
The second, more comprehensive phase is in the permanent dentition, typically ages 12, 18, to achieve definitive alignment of the dental arches and aim for a normal, functional occlusion how the upper and lower teeth bite together. This later phase may also involve preparing the patient for orthognathic jaw alignment surgery if needed at skeletal maturity.
That leads us to the final stage of surgical interventions discussed in the source, secondary or revision surgery. What's the purpose of these procedures?
These procedures are undertaken later in the patient's journey to improve either the aesthetics or the function, or both, that haven't been fully optimized by the primary stage surgeries. The source refers to these as unplanned procedures compared to the initial planned sequence as they address residual issues.
Cleft lip and nose revision seems quite common.
It is. The indications for revisional surgery depend on the specific site and severity of any residual deformity remaining after the primary repair. For the lip, relative indications might include minor misalignments of the vermilion border, the edge of the lip, or overall lip asymmetry.
And for the nose, the source shows figure 50.9 illustrating asymmetry.
Residual nasal deformity is very common due to the initial disruption of the muscles pulling on the nasal structures. Relative indications for nasal revision include issues like an incorrect position of the alar base, where the nostril attaches to the cheek, poor projection or shape of the nasal tip, or deviation of the cartilaginous nasal septum into the non-cleft nostril, which can affect breathing. The source explicitly states that this residual nasal deformity is often an external sign of incomplete reconstruction of that crucial nasolabial muscle ring during the primary lip repair.
That's fascinating. The aesthetic issue in the nose can be traced back to the functional repair of the muscle in the lip.
It really highlights the interconnectedness. The source notes that it's generally considered less ideal to perform major surgical intervention on the nasal septum while a child is still growing.
Okay.
Minor adjustments might be possible before age 14-15, but more major nasal surgery to correct the structural deformity is usually delayed until after this age, when nasal growth is more complete and stable. Figure 50.10 shows examples of results after definitive nasal revision.
What surgical approach is typically used for this definitive nasal correction in cleft patients?
The source mentions open septorhinoplasty as the preferred approach. An open approach, which involves an incision across the columella, the strip of tissue between the nostrils, is favored in cleft patients because it provides direct access to visualize and manipulate the external cartilaginous framework of the nose, which is frequently affected by the primary deformity and needs careful reshaping.
And what specific problems are addressed with that access?
Common issues needing correction include collapse of the lower lateral cartilage on the cleft side, which supports the nostril shape, and dislocation of the cartilaginous nasal septum, which often deviates towards the non-cleft nostril.
Right.
The open method allows the surgeon to reposition these cartilages and the septum. Grafting techniques, often using the patient's own cartilage harvested from the nasal septum or the ear, chondral cartilage, are frequently used to support the reconstruction and improve the shape and projection of the nose.
So rebuilding the nasal structure with cartilage grafts. Finally, orthognathic surgery or jaw alignment surgery. When is this needed in cleft patients?
Orthognathic surgery is indicated when there is impaired growth of the midface,
Yes.
specifically the maxilla or upper jaw. This impaired growth is multifactorial. While genetics play a role, local factors resulting from the primary surgical repair may also influence midface growth.
And the procedure.
It's an elective procedure to correct a jaw size discrepancy. It typically involves either maxillary advancement, moving the upper jaw forward, or bimaxillary surgery, correcting both the upper and lower jaws.
Okay.
The purpose is to restore both facial aesthetics and dental occlusal harmony, getting the bite correct.
Timing for orthognathic surgery.
Like definitive nasal surgery, it's usually postponed until facial growth is complete. This typically occurs around age 16-17 in female patients and 17-19 in male patients.
Right.
Performing it after growth is complete ensures the results are stable and not altered by further skeletal changes.
And what is the main skeletal problem being corrected by this surgery?
The principal dentofacial deformity associated with cleft lip and palate that leads to the need for orthognathic surgery is an underdevelopment of the maxilla in both the horizontal, front to back, and vertical up and down directions. The source notes that orthognathic surgery is performed to correct this jaw size discrepancy, as illustrated in figure 50.11, which compares the skeletal relationship in a patient needing orthognathic surgery versus one who has achieved a good outcome without it.
Okay.
So orthognathic surgery is often the final major step in the skeletal reconstruction, addressing the growth discrepancy that can persist despite earlier interventions and completing the journey towards optimized facial form and function.
This has been an incredibly thorough journey through the complexities of craniofacial anomalies and specifically the intricate staged management of cleft lip and palate. The source material, as dense as it is, really lays out the blueprint of care.
It does. The source's Summary Box 50.6 provides a concise recap of key aspects: the sensitive timing of cleft surgery, the importance of measuring both aesthetic and functional outcomes, the central role of restoring muscle position in surgery, the planned nature of bone grafting for alveolar clefts, and the role of revision surgery for optimizing outcomes.
Right.
It also highlights the shift towards organized MDT care, structured training for surgeons, and the emphasis on evidence-based practice driven by outcome data collection.
It's clear that managing these conditions is a highly structured, long-term process requiring immense coordination and specialized expertise across many fields. You, our listener, now have a much deeper understanding of this journey, from the initial diagnosis and immediate challenges to the staged surgical repairs and the ongoing long-term follow-up that can span 2 decades or more. It's about addressing foundational developmental issues and supporting a person's function and well-being through key stages of growth.
What's truly fascinating is seeing how the detailed understanding of how these conditions develop at an embryonic level directly dictates the surgical strategy throughout a person's life. The focus on reconstructing muscles, the timing of interventions linked to growth stages, the need for bone support tied to tooth development. It's a remarkable interplay of embryology, anatomy, surgery, and long-term care planning.
Right, connecting the dots from the very earliest cellular processes to surgeries performed in adulthood. It makes you wonder about the future. We've discussed this established long-term multidisciplinary model. If we think about potential future advancements, perhaps even more precise genetic editing therapies that could prevent some of these issues at the earliest stages, or bioengineered tissues that could integrate more seamlessly than grafts. It's you. This raises an important question. How might those groundbreaking future technologies potentially integrate with, or even fundamentally change, this well-established staged care model that's been developed over decades? Could the timeline shift? Could the nature of the interventions become less invasive or require fewer stages for future generations? It's a compelling area for thought, building on the incredible progress that's already been made in understanding and treating these complex conditions.